I start, sir?
Yes, yes, please.
Okay, sir. Good evening, and I welcome all of you in the third session of this IAP NRC General Club. Especially, I welcome our chairperson, Dr. Rawat sir, Dr. Bafna sir, Dr. Kabra sir, my mentor as well as great teacher, our presenter, Dr. Suman Bist, and other dignitaries in the DAC, Dr. Indu ma'am. I think Dr. Joseph sir yet to join. So I invite Dr. Indu Khosla ma'am, our national coordinator, to start this program. Ma'am, please.
Welcome all of you to this third session of the Journal Club. And I think it's been a great learning experience for all of us. We are learning from the students who are presenting. Well, all of us are learning how to analyze a paper, and with expert comments from Dr. Matthews, and today we are with us Dr. Kabra. I'm sure it's going to be a learning curve for all the fellows and all of us. I thank Dr. Rawat for this initiative. Without much ado, I will invite Dr. Suman to start her presentation. And once you finish your presentation, I would request people who have questions to put it in the chat box. We will have then Dr. Matthews, Dr. Kabra give comments on your presentation and look at your analysis. And we will discuss that forward from there. Over to you, Dr. Suman.
Thank you, ma'am. Thank you, ma'am. I'll be sharing my screen. A very good evening to everyone. I'll be starting with the article today. So the article is the Pediatric Empyema Thoracis Management. Should the consensus be different for the developing countries? It was written by Gauri Shankar et al., published in Journal of Pediatric Surgery in the year 2020. Our agenda for the today will be discussing the article, followed by the critical appraisal by the CASP tool, and then we'll have a literature review. We'll be seeing other RCTs which have similar designs and what were the outcomes of those RCTs. We'll have a final conclusion slide, and at the end, we'll have an open discussion and the expert comments. A little bit intro about the subject. Empyema thoracis is a major cause of morbidity in the children. 1 to 3% of the pneumonia cases are estimated to be complicated by the pleural infection. The clinical course of empyema can be divided into 3 stages as per the ATS guidelines. Stage 1 is the exudative phase that is characterized by the effusion with a low cellularity, which is free of bacteria and appears as a clear fluid on ultrasound. Stage 2 is the fibropurulent phase that is characterized by the pleural fluid but with a higher cellularity and the bacterial presence along with the septations or loculations of echogenic fluid collection as it appears on the ultrasound. And stage is the organizational phase that is characterized by the reorganization of the fluid into solid fibrous peel or thick membrane, which prevent the lung expansion. So the treatment per se for the empyema is the antibiotics to begin with, and the first initial intervention is the ICD, is the initial standard. But apart from it, if the systemic or the respiratory systems symptoms persist, and there is a evidence of collection, the patient might require debridement either in the form of the chemical versus a mechanical debridement. The add-on treatments which are available as of now is the medical in terms of ICD with intrapleural fibrinolytic therapy, or in terms of the surgical ICD with the video-assisted thoracoscopic surgery or open thoracotomy. Regarding research in context to this subject, various pediatric trials have concluded that both VATS and IFT have a similar outcome. But there is very limited data from the developing countries that compare both these modalities. At present, no RCTs from the developing countries that evaluate the outcome from the VATS and IFT. Though some guidelines have supported that intrapleural fibrinolytic therapy can be considered as an initial therapy before the surgical intervention, as suggested by the American Pediatric Surgical Association guidelines and the British Thoracic Society guidelines. Let's start our article for the today. So this article objective was to determine if IFT is equivalent to the video-assisted thoracoscopic surgery in treating the stage 2 empyema in children, even in the developing countries. Coming to the PICOT format, the population taken was the children with parapneumonic effusion with corroborative radiological finding and the pleural fluid analysis. Our intervention was intrapleural fibrinolytic, with the comparator being the patient undergoing the VAT surgery. The primary outcome was mentioned as the length of the stay post-intervention, and there were other secondary objectives. And the time they were followed up 6 months post-discharge, and it was an in-hospital-based setting. The outcomes, as mentioned, it is the primary outcome which we'll be considering among the two modalities is the length of the post-intervention hospital stay. And the secondary outcome was we have to assess the success rate, what were the complications seen, cost involved in the procedures, days on the ICD, need for the intensive care, CT scan requirement, and need for the blood transfusion. Coming to the methodology part, this was the prospective randomized controlled study, non-inferiority design. The setting, it was done in the Indira Gandhi Institute of Childhood, Bangalore. The duration of the study was August 2015 to September 2017. And this study was approved by the Institution Review Board, and this has been registered with the Clinical Trial Registry of India. The funding was done by the Rajiv Gandhi University. Funding was done by the Rajiv Gandhi Institute of Health Sciences, Bangalore. Sample size collection. The sample size was estimated based on the difference in the length of the hospital stay. Considering the non-inferiority margin of 3 days with 5% level of significance and study power of 80%, study sample required for assessing this was 18 per group. However, for assessing the non-inferiority in the treatment success, the sample size required was 30 per group. The author have already mentioned that because of the funding issues, the sample size could not be achieved. The inclusion and the exclusion criteria for the study. The inclusion criteria was all the children less than 18 years with a clinical course of parapneumonic effusion with empyema. The definition of empyema used in the study was X-ray finding or ultrasound thorax that showing echogenic collection with septations, and a pleural fluid analysis that shows either flank pus or exudative effusion that is suggested by the glucose level below 60 milligram per deciliter or pH below 7.2. Exclusion criteria being the major comorbidities, thoracic surgery, any bleeding diathesis, tuberculosis, any known hypersensitivity to the fibrinolytic, children with a complicated pneumonia like lung abscess, necrotizing pneumonia, bronchopleural fistula, as determined by the radiological assessment, were excluded. Apart from it, if there is evidence of air leak after ICD insertion was excluded from the study. So the procedure, the children with the stage 2 empyema, ICD was placed in the minor OT or ICU under sedation, and these children were reassessed after 24 hours. They were reassessed in terms of the clinical. Were there any changes in the clinical symptoms? Secondly, what was the volume of the collection drained? And radiological.
Yeah, they just give a command and
X-ray and ultrasound thorax was done after 24 hours. So seeing that the children were divided into two groups, one who improved and other who didn't improve. One who improved, we assessed whether they are afebrile, there's no signs of respiratory distress on room air, and imaging showing gross clearance were improved and they were excluded from the study. And were those who failed to improve or there was persistence of the collection is there, they were randomized to either of the arm, VATS versus IFTM. So randomization was a computer-generated random sequence of 2 blocks was done. The protocol was clearly mentioned for both the fibrinolytic therapy and the surgery. For the fibrinolytic therapy, the urokinase was the agent which was used and dosage was based on their age. As that mentioned that less than 1 year, 10,000 unit was dissolved in 10 ml of the normal saline, and for more than 1 year, 40,000 IU was dissolved in 40 ml of normal saline. The dwell time was 30 minutes when the installation was performed twice daily, and 6 installations were given over a period of 3 days. And for the surgery, VATS was the first recommendation, followed by, if required, the children who developed complication or did not achieve the satisfactory clearance with the VATS, they required open thoracotomy. Now, criteria for the success and failure of the treatment of each arm was clearly mentioned. In IFT group, the success was determined in terms of a clinical improvement in fever, respiratory distress, and gross clearance of collection on chest X-ray and ultrasound upon completion of therapy. And the failure was determined by if there any worsening of the clinical and or radiological finding during the course, or if there are persistence of collection evidenced by the X-ray or ultrasound at the end of 3 days. In the VATS arm, success was defined by when if no subsequent intervention was required for any pleural disease. And failure was required when the children developed complication or did not achieve satisfactory clearance with VATS, or they require any open, or they went into requiring open thoracotomies. Post-intervention care and follow-up, author have clearly mentioned that both the cohorts have received equal amount of care in terms of analgesia, antibiotic, chest physiotherapy, and nutritional diet were advocated. Both the cohorts were monitored for the complication in terms of bleeding, any idiosyncratic reaction after fibrinolytic instillation, prolonged hospitalization, injury to the surrounding structures at the time of VATS. They were discharged after successful therapy and ICD removal. Oral antibiotics were prescribed for a period of 10 to 14 days. However, they haven't mentioned which antibiotics were prescribed. And they have mentioned that follow-up was done for these children in both the cohorts at 2 weeks, 4 weeks, 3 months, and 6 months as required. Statistical analysis, all the demographic details, the baseline laboratory workup, including pleural fluid analysis, intervention, and their outcomes and complications were noted. And the difference in the baseline characteristics and outcomes was studied for their statistical difference by the non-parametric methods with the with the significance level they have mentioned as p less than 0.05. This was the trial profile. As we can see, when the study started, the enrollment, there were 48 children were enrolled in the study. 6 were excluded as they improved, and 42 were left who were randomized, and they were allocated to either arm, either VATS or fibrinolysis. 2021 each. In the VATS arm, one did not receive the allocated intervention as the parents preferred another modality. However, all the children who were allocated to the fibrinolytic arm, they received and they completed all the treatment. Both the cohorts were followed up and analyzed at the end of the study. In the VATS arm, the denominator was 20. However, the number of children allocated to the VATS arm was 21. And in the fibrinolytic arm, the number at the end was 21, and 21 only allocated to the fibrinolytic arm. So it is not clear whether analysis was done as per the ITT versus per protocol analysis. Coming to the result of the study. So as we can see, the demographic details of both the arms, total number at the start of the randomization were 42. Among them, 20 were in VATS and 22 in fibrinolytic arm. However, there is a certain discrepancy between the numbers, as in the consort 21 was written for each of the VATS and the IFT group. Rest of the demographic details, as we can see, as per the age, gender, the duration of the symptoms, the thickness of the collection in ultrasound in centimeter, both the groups are fairly comparable. However, in the socioeconomic status, number belonging to the fibrinolytic group, they belong more to the number of BPL families are more in the fibrinolytic group as compared to the VATS group, and hemoglobin is slightly on the lower side in the fibrinolytic arm. Coming to the outcome of our study, outcome in terms of IFT versus VATS, the primary outcome was our length of stay. As we can see in both the arm, the mean length of stay in the fibrinolytic arm was 7.8 days versus the VATS arm of 9.18 days. The difference between the two outcomes mean length of stay is 1.38 days. And the result is statistically non-significant with p-value of 0.24. The secondary outcome, as we can see, the success rate is more in the fibrinolytic group, 95%, as compared to the VATS group of 90%. Coming to the cost-effective analysis, the cost is more in the VATS group, $255 per patient, as compared to the urokinase group of $140 per patient. Complications have been mentioned, 4 in the VATS group and 2 in the urokinase group. As we can see, there is a statistical significant difference in terms of the CT scan and the blood transfusion requirement in both the arms. CT scan and blood transfusion is more in the VATS arm, and failure rate is more in the VATS arm, 10% as compared to the 4.7% in the fibrinolytic arm. On outpatient follow-up at 1 month, 3 months, and 6 months, all the children were clinically asymptomatic. They had X-rays showing good lung expansion and varying degree of pleural thickening. The author's limitation for the study is they have mentioned that it is being a single center, has a small sample size, and it lacks a sufficient power to examine the non-inferiority in the treatment success percentage. And there is a lack of comprehensive assessment of the nutritional status. The strength of the RCT being it's the only RCT from the developing country that evaluate the outcome between the VATS and the IFT. Author's conclusion says that fibrinolytic therapy is non-inferior to VATS in the treatment of the stage 2 empyema in children in the Indian subcontinent. So after this, we'll be going ahead with the appraisal tools for the RCT. Randomized control trial, the appraisal for this trials, RCT, we have for the single RCT, we have three tools available. CAS, that is Critical Appraisal Skill Program, that we'll be using for our study. Second is the JEDAD scale, and third is the Cochrane Risk of Bias tool. JEDAD score, also known as Oxford Quality Scoring System, it's the numerical score ranging from 0 to 5. The highest score indicate better quality. It is used to evaluate 3 items: randomization ranging from 0 to 2, blinding 0 to 2, and account of all the patient on 1. Total 5 scoring is there. If the score is more than equal to 3, that indicates a high quality trial. Coming to the Cochrane Risk of Bias tool, it basically assesses the risk of bias in RCT. There are a fixed set of domains of bias. For each domain, the risk of bias is judged as low, high, or some concern. The domain 1 being the risk of bias arising from the randomization process. Domain 2, the risk of bias due to deviation from the intended interventions. Domain 3, the missing outcome data. Domain 4 is the risk of bias in measurement of outcome. And domain 5, the risk of bias in selection of the reported result. Coming to our critical appraisals CASP checklist. So CASP is basically a structured framework that helps to assess systematically the trustworthiness, relevance, and the result of the published papers. They are divided into 4 sections. First section focuses on the study design, whether it is valid for the RCT, that is comprising of 3 questions. Section B, the study methodological, is it sound or not? It also comprises of 3 questions. Section C deals with the results, comprising of 3 questions, and section D helps us to know whether the results helps locally, comprising of 2 questions. All the questions are answered in the form of either yes, no, can't tell. There is no formal scoring per se. At the end, appraisal summary is being given. So coming to section A, is the basic study design valid for the RCT? Comprising of 3 questions. The first question being, did the study clearly addresses a clearly formulated research question? The points to be considered are, was the study designed to assess the outcome of an intervention? Yes. And is the research question formulated in terms of Picot format? So this is a discrepancy because there are 2 different questions which is asked in the study. First is the fibrinolytic therapy equivalent to VATS in treating the stage 2 impairment in children in the developing countries, which is mentioned in the abstract? Secondly, at the end of the introduction, they have mentioned that the study was done to assess the efficacy of fibrinolytic therapy in the management of type 2 impairment. This is the thing. In the introduction, they have mentioned this. And at the end of the introduction slide, they have mentioned that study was performed to assess it. So whether it was a comparative analysis or study done to study the efficacy of fibrinolytic therapy, the question of the was not clearly formulated. The research question was not clearly formulated. So answer is no for this question. Second is, was the assignment of the participants to intervention randomized? How was the randomization carried out? They have clearly mentioned that the block randomization was done. Was the randomization sufficient to eliminate systematic bias? Yes. Was the allocation sequence concealed from the investigators and participants? This is not clearly mentioned whether allocation concealment was done or not. So answer is yes for this. Third is, were all the participants who entered the study accounted for its conclusion? So the points to be considered were losses to follow up and exclusion after randomization accounted for? Yes. Were the participants analyzed in the study group to which they were randomized? So they haven't clearly mentioned, as in the VATS I have mentioned, there was one dropout in the VATS arm, but in the analysis, it wasn't considered in the denominator. So intention to treat analysis is not there. And was the study stopped early? If so, what was the reason? There was no interim analysis done in the study. Yeah. Coming to the section B, considering was the study methodological sound, it comprises of another 3 questions. Fourth question is, were the participants blinded to the intervention they were given? No. Blinding was not mentioned in the study. Were the investigators blind to the intervention they were given to the participants? Answer is no. Were the people assessing or analyzing the outcome blinded? No. There was no mention of blinding in the study. Next question is, were the study groups similar at the start of the randomized control trial? considering the points are, were the baseline characteristics of each study group clearly set out? Yes, and they were comparable. The demographic profile was comparable in both the arms. Secondly, were there any differences between the study group that could affect the outcome? No. So apart from, sixth question is, apart from the experimental intervention, did each study group receive the same level of care? That is, were they treated equally? So the points to be considered were, was there a clearly defined study protocol? Yes. If any additional interventions were given, were they similar between the study and group? Between the study group, yes. Both the groups were given similar treatment apart from the experimental intervention. And were the follow-up intervals the same for each study group? Yes, they both were followed at a clearly defined follow-up protocol. Section C, coming to the what were the results? Seventh question is, were the effects of the intervention reported comprehensively? Considering the point, was a power calculation undertaken? Yes. 80% power with 5% level of significance they have mentioned in the study. The sample size was calculated based on that. And what outcomes were measured and were they clearly specified? Yes. How were the result expressed? Like for binary outcome, were relative and absolute effects reported? It was. And were the result reported for each outcome in each study group at each follow-up interval? Yes. Was there any missing or incomplete data? No. Was there a differential dropout between the study group that could affect the result? No. Were the potential sources of bias identified? Yes, in terms of blinding and the allocation concealment, which we cannot comment on. Then which statistical tests were used? They are clearly mentioned and p-values were reported. Eighth question, was the precision of the estimate of the intervention or the treatment effect reported? Considering the point, were confidence interval reported? Yes, for the primary outcome they have reported. Do the benefits of the experimental intervention outweigh the harms and the cost? The 3 points to be considered, what was the size of the intervention or the treatment effect? In terms of the length of stay, that was the primary outcome. They have written that the difference in the length of stay of 1.38 days. Were harms or unintended effects reported for each study group? Yes. Was a cost-effective analysis undertaken? Yes. Section B, will the results help locally? There were 2 questions. Among them, 10th question was, can the result be applied to your local population or in your context? The points to be considered are the study participants similar to the people in your care? Yes. Would any differences between your population and the study participant alter the outcomes reported in the study? No. Are the outcomes important to your population? Yes. Are there any outcomes you would have wanted information on that have not been studied or reported? In terms of the long-term output, I would suggest the effect on the spirometry, lung function could be assessed on the follow-up. And are there any limitation of the study that would affect of your decision? That is, yes, this being a small sample size and single center study. Would the experimental intervention provide greater value to the people in your care than any of the existing intervention? The points to be considered are, what resources are needed to introduce this intervention, taking into account time, finances, skills development, or the training needs? So the intervention which we are taking into account is cost effective, is something that doesn't need a much more skill to learn and easy to administer. Are you able to disinvest resources in one or more existing intervention in order to be able to reinvest in the new intervention? Yes. So the appraisal summary is in the form. The points favoring positive or methodological sound. This study have appropriate randomization. They have comparable study population characteristics. Objectives and protocol for the intervention were clearly specified. Outcomes were comparable and undesired outcomes were insignificant. And cost-effective analysis was done. However, the negative or relatively poor methodological being the small sample size as of leading to lack of external validity. There was no blinding mentioned. And something that we are unknown about is the allocation concealment and whether the analysis was done as intention to rate or per protocol analysis. So this is a slide showing showing the different RCTs which has been done in the past. All the it was done in 2006, 2009, 2014, and our study of 2020. As we can see in all the studies, the intervention arm, the IFT, interpleural fibrinolytic, is the urokinase which is the most common used. Only in the St. Peter, it was the interpleural L-teplase was used. The comparator arm being the VATS, and all of them, they have taken the primary outcome as the length of stay post-intervention. And secondary outcome in terms of the cost-effective analysis, only Samatha Sonappa et al. And our study have taken the cost-effective analysis between the VATS and the IFT group. Coming to the result, as we can see, the length of stay in each study is comparable between the IFT and the VATS arm. And the results are quite statistically non-significant. And the failure rate also we can see they are 16% in both Samatha and the St. Peter et al. Study. And the failure rate in both the arms, IFT versus the VATS arm, they are both comparable. And authors' conclusion for all the RCTs, they have said that both VATS and IFT have a similar efficacy. And when it comes, the only thing is that IFT is much less costly as compared to the VATS. And this has been studied only in the two of the RCTs. This is basically a living systematic review and network meta-analysis, which was published in the Chest Journal in 2023, that is comparing the conservative and the surgical modalities in the management of pediatric parapneumonic effusion and empyema. Basically, it includes meta-analysis of 11 RCTs with 590 total pediatric patients. The interventions included the chest tube alone, chest tube plus fibrinolytic, thoracotomy, or VAT surgery. Their primary outcome is the length of the stay, and the secondary outcome included the cost, complication, and re-intervention rates. They have collected the literature search. They have collected the data from the different databases, and this database gets updated every 4 months with newly published research. So they have given the outcome that chest tube alone was associated with a longer length of stay compared with the other treatment modalities. The lower cost associated with the chest tube plus fibrinolytic warrants consideration when choosing between the treatment option, given similar length of stay and the clinical outcome compared with the other modalities. As we can see, the length of stay they have compared with the chest tube alone. In the fibrinolytic versus the chest tube, it is 2.46 versus 7.64 days. In the thoracotomy group, it is 3.17 versus 9.5 days. And the VATS group, it is 3.38 versus 8.35 days. So the final conclusion is the failure of the stage 2 empyema response to the ICT drainage and antibiotics needs chemical or the mechanical debridement. Factors playing major role in developing countries include duration of the illness, local expertise, cost effectiveness, and the nutrition status. Both VATS and IFT have comparable safety and efficacy, but VATS is costly. It needs more multi-center studies with large sample size to study the treatment efficacy. Thank you.
Thank you very much, Dr. Suman. Has Dr. Matthew joined?
Yes.
I don't see him.
Yes, I can hear you. Thank you, madam.
Yes. Okay. Thank you for that presentation. I would first now invite comments from Dr. Matthews on the presentation, and then we would throw questions at Dr. Suman also.
Yeah, thank you, madam. I think she has done a very good job, at least summarized very nicely. And the unique thing in this journal club has been that she has also gone ahead and tried to look at the other existing pieces of evidence. This is a new kind of trend nowadays in which we don't look at one piece of research in isolation, but we also try to look at the entire body of evidence and try to come to a common conclusion from all of this. So that's a plus, which she has done very well. But on the other side, there are a few things in the critical appraisal which are important to understand. The first is that the research question was actually quite clearly defined in this. So, in the sense that they set out to look at the difference between VATS and intrapleural fibrinolytic therapy after the patients had been given a chance to recover without any other measure than a chest tube. So that is important to understand. The second thing is this trial was designed as a non-inferiority trial. A non-inferiority trial is very different from the usual kind of randomized trial, wherein you're trying to establish the superiority of one intervention over another, because it has implications on the way the sample sizes are to be calculated. So in a non-inferiority trial, usually the sample size goes much higher than a superiority trial, simply because the philosophy of the two is different. In a superiority trial, we try to show that the two groups, one is superior to the other, and therefore, if a difference was detected, we have to see whether the difference could be by chance or otherwise. In a non-inferiority trial, the premise is the other way around, that it's everything is because of chance, and you have to struggle to show that something is not inferior to another, not by chance alone. So that pushes up the sample size, and the logistics therefore become much more complicated. Now, in this, even though she said that it's not strictly an intention to treat analysis, but if you look at it, out of the 42 patients which were randomized, one patient never got the intervention because the parents did not want to remain the arm that they had chosen for the child. So practically speaking, this would be what is called a modified intention to treat analysis. Fourth important observation is that even though the efficacy things looked similar, there is a lot on the safety front. So if you look at the VATS arm, they have mentioned 2-3 things there which have not happened with the fibrinolytic arm, and that is some children required transfusions during surgery, some children have developed subcutaneous emphysema, a couple of children developed one or two other complications also, which overall seems to suggest that the fibrinolytic arm less frequently associated with complications than the VATS, which is a great strength.
So we've lost you.
Because managing complications would require additional inputs of healthcare. I'm not audible? Not audible at all? Hello?
Sir, you are not audible.
I think it's
Oh, I'm not audible, is it?
Yes, sir. You are not audible.
Okay, so then what I do is I'll stop speaking and
The
try to
last-
get a more stable internet.
Yeah.
And then
Last last few comments were not audible, sir.
The
few comments.
last two lines, sir.
Okay, so what I was trying to say is that even though efficacy wise the two interventions did not show a difference, in terms of safety, surprisingly in this study, VATS was associated with more side effects in terms of blood transfusion, also in terms of subcutaneous emphysema, and a couple of other non-specified adverse events. So on the safety angle alone, even though the efficacy was similar, the trial would end up favoring more of the IPFT kind of a thing. The third thing is, what they have done here is not strictly a cost effectiveness analysis. It is just a cost analysis, and we all know that surgical treatment would end up being more expensive. One thing which has not been looked at in this study, which they could have probably considered, is if they had a larger sample size, clearly some children in both the groups would fail the treatment. And then what would happen if they were switched to the other arm? That has not been looked at in this because everybody just went ahead and underwent thoracotomy if they did not succeed in their treatment. I think on these preliminary considerations, it's otherwise a decent trial, not great, but pretty okay. We will now take up the rest of the discussion and see. Thank you.
Thank you.
Yeah. Dr. Kabra, can I request you to make your comments?
Okay. Thank you very much. She presented very well, and Dr. Joseph Matthew has discussed it very well. So let us see. First part is about this paper, and then we decide about whether we should change our practice or what are the problems. So first and foremost is that authors decided to do this RCT because there are no studies from developing countries or India. And they took the primary outcome variable as the length of stay. Length of stay is not a big issue as far as developing countries are concerned because the stay cost is less. And then at the same time, who decides? They have not very clearly defined that who decides about the discharge because it is a non-blinded, so there will be some bias. Third thing is that if you want to say that it is non-inferiority, then you fix a time that I would consider that if it is difference is within 5 days of each other, then that is clinically relevant and it may be a good outcome variable. But if you say that 2 or 3 days difference between these two, then clinically it may not be relevant as far as developing country is concerned. Obviously, there was no mention about the allocation concealment, and there may be some bias. So, just for the audience, that how you can do a allocation concealment in a non-blinded. So, you keep the serial number of the patient in a opaque envelope so that you do not know to which group it will go. So these are the things. And as far as the final outcome is concerned, she has already shown a living randomized control trial, this systematic review of all the 11 RCTs done till now. So it is otherwise add to the existing knowledge, the current study, but otherwise it is beyond doubt that the intervention in form of a fibrinolytic agent or VETs definitely better than putting a ICD and its length of stay in the hospital. Now the other thing is that any intervention, whether it is a immediate outcome, that is the length of stay, complications, and other thing. And other thing is what would be the long-term outcome, whether it affects the outcome in form of a spirometry. She brought out it clearly that that was not studied over here. So for changing my practice, I accept that in India, we are more confident in putting a ICD and giving antibiotics, but we are slightly conservative as far as these fibrinolytic agents are concerned. But we have to encourage more, and we should use it more frequently to reduce the surgical intervention and surgical morbidity. Thank you.
Yeah. Okay, so there are a few questions for you. Okay, so I'll take them one by one, and I have some comments for you, which I will conclude later. Okay, so one of the questions which even I had was in the IAPFT arm, there were more children with malnutrition. And can it affect the result? And my comment on this is they were in this study, they had not looked clearly into the evidence of malnutrition. They were detailed in evaluation of children. Nutrition status was not done to categorize. Could you comment on that, or did you find more data on how did they look at the evidence of the level of nutrition in these children?
Apart from this, the other studies have not considered malnutrition as one of the objectives. And they have mentioned that 6 children had malnutrition, and they said they were, and like 4 of them were in the fibrinolytic arm. But they have also mentioned that they were comparable there was no significant difference between the normal and the malnourished. However, the sample which they have commented as 6 is very small to comment whether there will be a significant difference between the two or not.
Okay. Another question here is: would failure rate as a primary outcome, would failure rate as a primary outcome would have been a better proposition? Would that
Instead, I would say the success rate would be a better primary outcome in assessing the efficacy between the two arms.
So not failure rate.
Not failure rate.
Why do you say that?
We are clinicians. We want to see the treatment success efficacy.
Okay. Was there any comparison done on the microorganisms? I think there was some.
They have mentioned, as in the Western countries, the staph pneumoniae is more the predominant organism. In India, the staph aureus is the one. They have mentioned the culture yield was poor, and 2 of them grew staph aureus. One of them was MRSA. They have written in that.
So what was the criteria for them to decide which arm should go into the fibrinolytic group and which arm should go into the VATS group? Were there any other criteria to decide the two?
No, ma'am, just randomization, and just they have allocated to either of the arm.
Okay.
Antibiotic choices in both the group, ma'am, antibiotics was not mentioned, like which antibiotics were given to either of the arm. So cannot comment on that.
In your mind, are there any clinical predictors that should help you choose between the VATS groups? You have reviewed literature otherwise. So is there any clinical predictors which you can choose to decide who should get fibrinolytic therapy versus VATS? Or is there any data to
It
decide?
depends on, first of all, the duration of illness when the patient comes to us. It is the early stage or the late stage. Obviously, if patient comes in the late stage and it has become organized, then it eventually falls into the surgical arm rather than going for the conservative management. Secondly, that expertise. What if we don't have a surgeons in house, or like we can in the resource limited setting, we'll go ahead with we can give a trial of the intrapleural fibrinolytic. And then cost effective, obviously we need to consult and tell the parents that like we have two options available and both have the similar efficacy and outcome as the studies have shown. The only thing being the cost is there, and the length of stay would be much bit higher in the IFT group.
Dr. Rawat has one more question. Did they analyze the reason for failure for ICD?
Reason for failure of ICD?
There was one patient, right, who failed the IFT therapy.
They have mentioned that the intrapleural fibrinolytic group, basically the one patient was discharged and again he was getting repeated collection, and ultimately he underwent VATS and thoracotomy. They haven't mentioned why, the reason. That was one of the failure in the IFT arm. It was there.
All right. There's a comment here. Remember that late presentation with organization of pus would require open thoracotomy and not VATS. Yeah, that's
Yes,
fair.
ma'am.
Yeah. Any other comments from the house? Dr. Bafna, Dr. Rawat, Dr. Ajay Kumar?
So, Dr. Bish, thank you very much. So, do you think that the result of this study can be applied to an institution? Like, would you start using this particular inference of study that both are equal, VATS as well as IPFT? So, can you apply it right now, tomorrow itself, in your institution? Or if yes, why? If no, why?
Sir, considering just the result of this study, based on this study, there is a lack of external validity. I cannot apply, considering the small size. But in our institute, we have tried IFT as an initial intervention, considering the patient at what day of illness he is presenting to us, the ultrasound suggesting of the thin septations and location. We have given a fair trial of IFT in that group, and they have really done well, and we have discharged them. So we can give a trial of the IFT.
Yes, so I think to apply any method, you require very well made guidelines, and I want to inform you that IPNRC guideline group, they are at present developing guidelines for empyema, and we are going through all these questions which you have raised, and I'm sure within a month probably we are going to come up with evidence-based guidelines for empyema for our country, and definitely that will answer a question that IPFT or VATS as a choice of therapy. So till now we don't have evidence-based guidelines. Definitely, as what you have said, that there were previous various studies indicating that both are same, VATS as well as IPFT. But yes, we have no evidence-based guidelines. So definitely within a month, IPNRC is going to come with evidence-based guideline, and definitely it will answer the question.
And I think a very large number of children, depending on the centers that we have, depending on the presence of facilities, because VATS does require a lot of infrastructure to do it. And I think that is also going to be a very deciding factor in a country like ours, whether we should, of course, when the patient comes in late, the less options are left and you need to do a surgical intervention. But even many centers even do primary VATS, right? So, but I think it depends on your infrastructure that is available, the affordability of the patient, the cost of the patient. So there are multiple reasons also one can choose. Apart, of course, we definitely need evidence-based guidelines to see what is right for the patient. I think there's one more comment.
Yeah, here regarding the size is very less here, because almost like 40 patients. But when it they'll charge you around 25,000. So almost like 8 days, it will take 1 lakh 50,000. What we observe in corporate hospital, if we do wax, the patient can be discharged within 5 days. The length of stay will be reduced, the length of nosocomial infection will be reduced, the length of IV lines, everything expenditure will be reduced. I don't know, like uh, in the government hospital or the semi-government hospital, length of the stay will not matter. But when it comes to the corporate hospitals or private setup, the length of stay matters, madam. What I feel.
Yeah. We have many areas within India, so I think that is the reason.
Infection, as the length of the stay babies is more, the nosocomial starts setting within 48 hours or after 72 hours. Even I think in that aspect we should take because uh, we have because we didn't do study anything, madam. As you said that we have a better results with the vax compared to the fibrinolytic therapy. In the times of length of therapy, even the patient satisfaction.
Dr. Kasi, in my opinion, also in especially in the private setup,
Dr. Kasi, can you mute yourself? There's
where
lot
the
of
facility
disturbance.
for
Yeah, okay.
where the facility for VATS is available, especially in the private, I think it is better to go with the VATS to reduce the length of hospital stay. I think so. And in our government setup, when we see that there is thick pus, very thick pus, then we this use this euro streptokinase very early. We are not waiting for the 2 or 4 hours for draining the pus. If it is very thick pus, loculated, then I try this anti-inflammatory therapy very early. Although in our hospital, pediatric surgeons are more in favor of this fibrinolytic therapy rather than VATS. I don't know whether they are overworked or what, but they always tell us to give fibrinolytic therapy in place of VATS, although they have the facility for doing the VATS.
I think what we have little diverted from the basic concept of the journal club, where our aim was to just discuss the article and how we have to analyze the article. And we have diverted into a little bit into clinical guidelines. But it's, of course, these are finally welcome comments because that is what will matter in real life, right? Okay.
Like
Any other comments for the presenter, the way of the article being analyzed? Anything else that anybody wants to say? Dr. Kabra, would you like to add anything?
No, it's okay. It has been discussed very well.
Dr. Bhavna, you can give your final comments.
Good evening, everyone. Congratulations, Suman, for a wonderful presentation. I think she's done a good job. I wanted to say and ask Dr. Kabra sir and Dr. Matthew, when they, I think most of the studies, rather than failure or success rate, which is actually crucial, most of the studies are focused on length of stay. Now, length of stay in Western world may be protocol based, but in our setting, as sir was saying, it may be very subjective, because discharge criteria are not, fixed. And even in this study, they have not mentioned the fixed discharge criteria. These are the discharge criteria when we will discharge the patient. So length of stay, when the person is not blinded and there is no allocation considered, there is a lot of bias. And then it becomes very difficult to say whether this primary outcome is relevant. And rather than that, of course, the success or failure rate would be a better option. But I think there was a problem about sample size, and therefore they could not have that as a primary outcome. That was one. And of course, I think as sir has already said, that the take home from this article is probably we should not stop at ICD alone. And henceforth, I think if ICD is not working within next 24 to 48 hours, we should think of our options. And I see both the options probably at present look reasonable, and then we can choose depending on the expertise, cost, and feasibility, acceptability, etc. So that's my comment. And we at our hospital at Bharati, in last 3 months or so, I think almost 5 to 7 questions have received IPFT, and I think I would say maybe one of them would have gone for worse, but most of them could be discharged. So experimental basis or practical basis, I think clinically it is working, but obviously, as you said, we need more data and more sound data. Thank you.
I think there's a need of a multicentric study because we have lots of patients like this with empymas in our country, that there's no dearth of such cases. So the negative of the study was a small sample size. And if we can plan a multicentric study, it will be a good study to do that. And I think that would be a future direction for this kind of a study.
Madam, Dr. Joseph sir is responding to the question and answer using my ID.
Okay.
Yeah.
So,
He is replying the so many question answer using ID.
Dr. Bhavna, your comments are very well taken. Actually, the problem with this study is that it is not blinded. Like this study has been there in a systematic review, what we are doing in IPNRC guideline development group. And basically, the study has been downgraded because of the lack of blinding, and there are bias. So that's why this particular outcome of length of stay cannot be taken very effectively, because again the study is of low quality because of all the factors I told you. So I think in any RCT, whenever you are going to appraise it, blinding is very critically important, because if you are not blinded, all your critical outcomes they are affected, and the study gets downgraded. So as Suman has told us that this study there was no blinding even at the level of the investigators or assessors or the patient. They were not blinded. So that was a serious outcome which downgraded it. That's why the results cannot be taken in the way it should be. Although this study has been there in our systematic review, and the result will be out say after the end of this month. But again, I have to emphasize that blinding is a very important aspect of RCTs, and that must be there for an effective results. Thank you.
Thank you, Dr.
Thank you so much. Then there are no more questions. We'll conclude this session then. Thank you so much. Thank you, Dr. Chikumar. Thank you, Suman, for a lovely presentation. Thank you, Dr. Rawat and Dr. Matthews, Dr. Bhara.
Thank you. Good night, all.
Good night.
Thank you.
Good night, sir.
Yeah,
Good
good
night.
night, everyone.
Good
Thank
night.
you.
Good night,
Bye.
madam.
Bye.